The BAYOU trial is a randomized phase 2 study that was placebo-controlled, looking at durvalumab plus olaparib or durvalumab and placebo in platinum-ineligible metastatic urothelial cancer patients. These patients have a poor prognosis. The standard options in this scenario, at least in the United States, are immune checkpoint inhibitors like atezolizumab and pembrolizumab, although there remains a significant unmet need for patients in this population. We know that a portion of these patients have mutations in homologous recombination and repair genes, or HRR genes, and that might lead to sensitivity to PARP inhibition. In addition, there's other data that suggests that perhaps immune checkpoint blockade and PARP inhibition, even in the setting of wild-type HRR mutations, might lead to clinical benefit. And that provided the rationale for this randomized phase 2 study to determine whether the addition of olaparib will improve outcomes in these patients treated with immunotherapy. This was a randomized phase 2 study. Patients who had metastatic urothelial cancer who were ineligible for platinum chemotherapy. And it was defined as unfit for carboplatin-based chemotherapy based on the investigator's assessment, as well as one of the following criteria: creatinine clearance less than 60, greater than or equal to grade 2 hearing loss or neuropathy, or NYHA class 3 heart failure, or ECOG performance status 2. Overall, patients could be ECOG PS 0 to 2 if they met other criteria. And so the trial was randomized and stratified by HRR status and Bajoran risk criteria to either durvalumab and olaparib or durvalumab and placebo. And the primary endpoint of the study was progression-free survival by RECIST 1.1 in the ITT population, which is all patients. In addition, a pre-specified secondary analysis was planned of progression-free survival in patients who had HRR mutations in their tumors based on Foundation 1 sequencing. In addition, the overall survival and RECIST responses were secondary endpoints, in addition to safety and tolerability. About 20% of patients who enrolled on the trial had mutations in HRR genes. The most predominant ones were ATM and BRCA2 that were found in this patient population. And the intent to treat population, at the end of the day, the progression-free survival was no different. It was 4.2 months with durvalumab and olaparib and 3.5 months with durvalumab and placebo. That was not significant. However, in the pre-specified subgroup analysis of patients with HRR mutations, the progression-free survival with olaparib was 5.6 months, and with placebo was 1.8 months. And this hazard ratio was 0.18, quite impressive. The highly significant p-value, although it must be emphasized, it's a small subset of patients on the trial, and so must be interpreted with the same caution you might have with any other secondary analysis, although this was pre-specified. And so overall survival was also evaluated, and that was no different between the arms in the ITT population. Interestingly, we saw that the presence of HRR mutations appeared to lead to a poorer prognosis, regardless of the treatment arm, although in patients who received olaparib and had HRR mutations, their outcomes numerically were better in terms of overall survival by about 3 months. Although, again, not powered for overall survival. This was a secondary endpoint, and technically the trial was negative for overall survival, both in the entire subset population as well as the HRR patients. And so in terms of anti-tumor activity, the objective response rate in the HRR mutant patients was 35% if they received durvalumab and olaparib, and 0 if they received durvalumab and placebo. And in the ITT population, the entire study population, it was 28% with durvalumab and olaparib and 18% with durvalumab and placebo. And so it does appear to increase the response rate regardless of the treatment, although the benefit seems to be more with patients treated who have HRR mutations, but the time to event endpoints in the entire study population were not better if you received olaparib. And so the take-home message from this trial is that it appears there might be a role for olaparib and PARP inhibition in patients with metastatic urothelial cancer whose tumors harbor HRR mutations, that these mutations might sensitize them to either immunotherapy or just improve outcomes based on the known biology of PARP inhibitors in this disease. And we'll be seeing at GU ASCO other data that suggests that that might be the case as well in selected patient populations. And so, in my opinion, moving forward in unselected trials in urothelial cancer is unlikely to move the needle with PARP inhibition, but if we're looking at the right patient population, appropriately selected for mutations, we may in fact see benefits.